first thing to establish is that they do actually have a diagnosis of schizophrenia. It's surprising how often in my clinical practice, I work exclusively in treatment-resistant schizophrenia, patients are referred to our service who've actually got sometimes a mood disorder which is manifesting with psychotic symptoms, or sometimes even a personality disorder. And so it's important to go back and reconsider the diagnosis. So assuming that the diagnosis is correct, the other thing to look at is whether there are other factors, other comorbidities that might be contributing to a lack of response to treatment. And particularly I'm thinking here about substance misuse, which is particularly common in the area where I'm from, in South London, particularly cannabis. So assuming that the diagnosis is schizophrenia and that there aren't comorbidities that are influencing the picture, the next thing to establish is that the patient has actually had two separate adequate trials of antipsychotics. And by an adequate trial we mean that the person has to have been taking the medication, so their compliance really or adherence needs to be checked ideally, either through pill counts or perhaps even through plasma monitoring of blood plasma concentrations of the drug. And also the treatments have to have been of adequate length, which usually means at least 4 weeks, and of an adequate dose, so that's usually, well, a therapeutic dose. If all of that's been done and the patient does indeed have treatment-resistant schizophrenia, it's a very frustrating situation for the patient and for the relatives as well as for the prescriber. The only evidence-based strategy in that situation is to prescribe clozapine. That is what most of our guidelines tell us to do. But what we know from the evidence is that actually that doesn't always happen. In fact, probably most people who meet the criteria for treatment-resistant schizophrenia are not actually on clozapine. So I'll give you some figures. There was a recent study using MacCabe data from the US, and that showed that in people who have a diagnosis of treatment-resistant schizophrenia, the proportion of new antipsychotic prescriptions which were clozapine was only about 5.5%, and that's the proportion in treatment-resistant schizophrenia, not just in schizophrenia overall. So that number should be near 100%. In a recent study in our centre in London, we found that patients wait an average of 4 years from the point when they actually meet criteria for treatment-resistant until they receive their first dose of clozapine. The reason why this is important is because the longer we leave clozapine treatment, the less likely it is to actually work.